Welcome to the Beyond the Spine podcast, where precision meets performance. I'm Dr. Bobby Fano, Gonstead chiropractor, educator, and performance strategist. And around here, we don't settle for average. We raise the standard because becoming better isn't something you stumble into. It's something you build through precision, discipline, and purpose. Each episode, I sit down with leading chiropractors, innovators, and performance experts to uncover the principles that drive real results in your body, in your mindset, and your mission. From biomechanics to belief systems, from clinical mastery to personal growth, we explore what it really takes to stay aligned with what matters most, so you can show up stronger in every area of your life. Whether you're a chiropractor sharpening your craft, an athlete pushing your limits, or someone committed to living at your highest level, you're in the right place. Because when the body is aligned, anything is possible. Starting now. Welcome to the Beyond the Spine podcast. I'm Dr. Bobby Fano, your host. And in today's episode, I'm interviewing Dr. David Sheekey. If you don't know him, to me, he's one of the OGs when it comes to Gonstead extremity care and being a Gonstead extremity expert, even before I met Dr. Working. And when I was a chiropractic student, just learning the technique, I was in the Gonstead Study Club at Life University, and I was studying to become a certified officer. And we used his book, A Practical Guide to Adjusting the Extremities, as one of our references to learning Gonstead extremities. And I reacquainted myself with this book recently, and I was wondering if Dr. Sheekey was still in practice, still around. So I reached out to him, and we had a great conversation. He just retired, but he was willing to come on and allowing me to interview him. So I'm super excited to deep dive with him into how Gonstead extremity care started and how he enhanced it throughout his career and where he sees Gonstead extremity care going in the future. So without further ado, please welcome Dr. David Sheekey. So Dr. David Sheekey, tell us about your chiropractic story.
Sure. I was always involved in sports and the health aspects of it as well. And I was in college, and I went to my uncle's chiropractor, and he allowed me to, sit in his office, and the patients were, compliant with me and allowed me to sit in there and go through their cases with them. And, just seeing people walk in pain and other types of ailments and be able to walk back out without, with just basically just getting adjusted without having any medical intervention. It just seemed to make the most sense to me. It was the healthier way to do things. And after that, that's all I wanted to do.
That's awesome. How'd you get into Gonstead extremities?
Well, Gonstead actually was introduced to me by my first roommate at chiropractic school at Life down in Marietta, Georgia, Dr. Brett Wartenberg, who's a Gonstead diplomate and also was the president of the New Jersey State Board. And having him as a roommate there, and he was vice president of the club on campus at the time, I had no other way to go. And plus, it just made the most sense to me. It just, everything was, analytical. There was nothing that wasn't left unturned. You had so many different ways to analyze a patient, and they all came together and gave you the answers that you needed to be able to help a patient and know what to adjust. So I think, if anything, he was the one that led me down the Gonstead path. And then the extremities, I kind of took an interest in that just from the standpoint of, again, being with sports and everything, there's so many different injuries that happen in sports that we as Gonstead chiropractors having access to extremity adjusting could add that much more to our practice and also help people in so many more different ways.
Absolutely. I know Dr. Brett.
Yeah, great guy.
I'm trained by Dr. Working, and he was friends with him. So we did a seminar back in the day.
Oh, yeah. No, he was great. Having him as a roommate there, he was always, ever had a question, he was right there. Even if I didn't have questions, he was still right there giving me answers. So
where did your training come from?
The extremities, we had it in school, but the class didn't quite take it far enough. It was Dr. Diane Saltzman, and she was good. She didn't things do Gonstead way, but she was able to give me a foundation for it. And then going up to Mount Horeb, I think that really solidified what I wanted to do with extremities. Dr. Doug Cox, especially, he he just had a smooth and effortless approach to them. And like when he did adjust, like first time he did my lunate for carpal tunnel, it was just so smooth. It moved, and everything was fine after that. So he just, having that many years of practice and seeing so many things up at the Gonstead Clinic in Mount Horeb, he really kind of pushed me along this path to go through with the extremities, if that much more.
Awesome. So what piqued your interest in writing your own extremity book?
Well, I think that the lack of information being out there on extremities, we had the chapters and the notes from Dr. Gonstead, but it only went so far. And it wasn't really a printed text that we could actually access and be able to have pictures to go with the words. So that's why I decided to go down that route and put something together that would be easily accessible to students and give them a little foundation for it. Again, nothing replaces getting your hands on patients and going over things. And just like we had in school, we had trauma sessions where we adjusted each other, and this was, I think, just the next step in the progression of learning extremities, having something out there that gave pictures and descriptions of what needed to be done. And then it's up to each individual clinician to take it to the next step further and get your hands on some patients and start adjusting extremities.
It seems like your book expands on chapter 20 of the Gonstead chapters. How did you get your information?
Well, again, I use the chapters as a foundation for everything. I also spoke to several Gonstead practitioners and got their clinical experience on how to do things. And because when you see things in writing, it's like a picture. It's one dimensional. You need to get your hands on people and get the experience from other people. And I think that's where a lot of things were lacking. That we needed to have something more, like I said, with pictures, and then basically applying it and getting your hands on other patients and on each other in school, and just getting more experience with it. No, I just talking to Dr. Alex and Dr. Doug. Once I wrote it up, I sent it to the manuscript to them for their approval. That it would be as something that the Gonstead Clinic and the seminar would be able to use to further extremity adjusting. Like I said, the chapters give you an in-depth, but again, we don't have pictures to go with it. Again, that's one of your questions I know was about what do you do further to kind of expand on the book. And I think having video would be the next step, which is something we could possibly do in the future, because there were some old tapes of Dr. Gonstead adjusting, and I had one. Unfortunately, I loaned it to somebody and never got it back. But
okay.
You know how that goes. But I think the progression of first the book with pictures, and I think the next step would be having possible video of showing the actual line of drive, the analysis of patients with different extremity problems.
If you were rewriting your guide to extremities today, what would you make any edits? If so, what would they be?
I think because I wrote it just out of school, I didn't have all the experience needed to expand on it. But now after the fact, I think having more case studies in there, because there's a lot of different symptoms, that are extremity related. But I've had people with TMJ problems, which is one of the most common things I see. Anybody's eating a big sandwich or gone to the dentist, you're going to have TMJ problems. But you can clear it out with an atlas adjustment sometimes. Not all the time, but it's something that you see out there. So coming out of school, wet behind the ears, we don't have that kind of experience. But after years of practice, you see these things, and it can help you, along the way. So if anything, I would expand on it in the book to have case studies.
Can you actually show us your process or describe your process of analyzing the TMJ?
Sure. I mean, that's one of my favorites, actually. So it's I have so many with different people, headband, headache. There's so many different symptoms you can have with the TMJ. Mm-hmm. But basically, there's two main ways I analyze it. The one, of course, is getting your hands in here. You can put them in the ears. You can just put them on the outside of the TMJ here. Have the patient slowly open their mouth and close. You can feel the opening and closing. You go by their symptomatology. A lot of times they'll tell you, okay, I've got this clicking on this side. So whether it's a AI on this side or a PS on that side. The mechanism of injury too, how they hurt it. Was it going to the dentist, having a filling done where they're prolonged, opening of the mouth? Was it from something where they were actually hit or something driven up? Because actually one of the first patients I had wasn't even one of my patients, but it was one of the best stories I've ever had for extremities. And I was in school, and there was another clinician in my class had a patient who lived on a farm, and I got hit by a barn door when she was 16 years old and hadn't been able to open her mouth more than an inch for 11 years. So she called me in to just check it out because she knew I was into the extremities. And I came around and I palpated it, open, closed. You could feel the closing and opening, but it wasn't very much. But you had an AI on the left side. And basically I said it, and I came around in front of her. I said, okay, now open your mouth. And for the first time in 11 years, she opened it all the way. And she was just so excited by it. She actually was like, I gotta go. I gotta go. She was just so excited by it. And that there kind of really, really embedded me in extremities that much more, because when you can see results like that in just one adjustment, I just knew this is what I had to do. And with the extremities, like, you have, AI, PS, lateral. And again, the analysis, I always like to see the patient so they know what I'm feeling as well. So I'll put a mirror in front of them as well. And I tell them, okay, just open your mouth slowly and you can see the deviation. It'll kick out one side and come back most of the time. So you can see, they actually see it. They don't know it. They sometimes feel it in their bite, different symptoms, headache, just pain on the one side or the other. And I like putting the mirror in front of them, and I tell them, just look at this here and watch, and you can see actually how it deviates. And when they can see, like they say, a picture's worth 1,000 words. Well, now actually seeing it visually, it kind of like lets them know, well, there really is something wrong here. So that's
100%.
Yeah.
When I was reading chapters about the sinuses, that one's hard to understand based on the text itself.
Okay.
But I know they did the best they could to describe, how the adjustment went.
Sure.
So in your book, you talk about milking the sinuses. Can you tell us more about that?
Sure, actually. And I actually, for Halloween, I brought a friend along the show.
Nice.
So the kids had it. So I was like, you know what? I could probably use this. So yeah, basically, the two sides, you have your maxillaries and you have your frontal. A lot of times people have sinus problems and they feel the congestion, the tightness, sometimes a headache, just the pressure. And by milking it, what I mean is, now if you're going to contact the maxillary sinus on the left side, you're going to stand on the right and you're going to use the thumb of your right hand. Now what you're going to do here is basically by milking it, I don't know if you can see me properly here, but what you're going to do is torque by putting pressure, torquing clockwise when you're doing the left sinus, maxillary sinus with your right hand. Now, transversely here, when you're doing the right side, you're standing on the left using your left thumb, and it's going to be counterclockwise. And basically, you're putting pressure. You'll actually feel a sponginess to that sinus when you're doing it, when it's the problem one. The other side, you'll actually feel it's kind of tighter. Whereas when the fluid in there, you can actually feel, some people say you can't, but you can feel that extra fluid in there, and the patient will tell you, wow, I feel that a lot different. It feels like there's something happening in there. So, and basically you just torque, and that's what I mean by milking it. So now with the frontal, what I'll usually do is I'll just use my pisiform, and I'll do two different areas because the frontal sinus is a lot bigger. And what I'll do is I'll contact it with my pisiform, and basically I'm just going to torque down and put pressure, and then move over slightly. And again, milk that one as well. And it's a torque. Just like when we adjust in cervical chair, torque is everything. That's how you get that depth. Dr. Gonstead used to take a pencil on the eraser side, put it into a balloon, and then just let it go. And the balloon would just kind of float off slowly. But if you take that pencil with the eraser side and you twist it in and then let the balloon go, it flies off a lot quicker. So it's the same thing. It increases the speed by the torque. So that's what you're doing here with that, with the torquing with the thumb or with your pisiform on the frontal.
Awesome. Super helpful. How about the nasium?
Yes.
What are your thoughts on that?
Actually, I adjusted mine this morning. So usually you find that in like cases of one-sided rhinitis where you have congestion on the one side. And basically you just come down off the nasal bone there. You'll feel that little piece of cartilage there. And it'll be spongy to one side and then kind of locked on the other side. So you go onto that side that's kind of locked up, and you just give a little impulse there. It's not much, but it's enough, and you'll actually get an audible out of it.
Will that change the deviated septum?
It can. It won't completely again, because sometimes a deviated nasal septum has to do with the bone structure as well. And we're not going to move the bone there just from the standpoint of, you could break something there with the vomer. So basically, as long as you get on that cartilage, you come down just below the bridge, you can feel the end of the, where the bone is there, and you can feel that cartilage piece there. And you can get there and you can set it back, and the sinuses will, will open back up with the nasum. Also with the sinuses too, I always tell people after they adjust them, make sure you have a tissue or two handy, because within 10 minutes, a lot of times things start draining out pretty quickly.
Okay. So you're retired, right?
Yes, I am. Yes.
Okay.
Doesn't mean I won't get back into it, but for right now, I'm enjoying retirement a little bit. So.
How many years did you practice?
33.
Awesome. So in terms of extremity care, what were the most common cases that you would see in practice?
I would have to say for extremities, TMJ was a very common one to see. A lot of people didn't even know they had it. They just thought they had these headaches from whatever. And I would see the pattern of the headaches and what they were going through, and determine it was a TMJ problem. And a lot of times carpal tunnel was the other one. So a lunate problem there. Shoulders were probably the third most common. Mostly AI or an AC joint problem, and also with a proximal scapula. So those are the main ones I saw over the years that really stood out as I don't say the most popular, but they were the ones that presented themselves. I think because, again, we're always eating, so the TMJ is always going to be affected. Shoulder-wise, you can't do most things that we do with life without using our arms, and the shoulders take the brunt of the force with it. So. And then the wrist, just working nowadays with computers all the time. People are on there; they're not using an ergonomically designed keyboard. So a lot of times that wrist being down, affects that lunate, and it causes a lot of problems. And people I had a patient when I first got out of school who went and had the carpal tunnel syndrome surgery on the one wrist and was waiting to have the other one. And I started adjusting that wrist, and she didn't need the surgery in it. So
awesome.
Yeah.
Never get sick of hearing miracles like that.
I tell you, it was great. It was 33 years worth, seen plenty of them, and it made life worthwhile. It really did.
So with the shoulder, in your opinion, in your clinical expertise, what's your relationship with the scapula and the proximal clinofemoral joint?
I would have to say, a lot of times when they present with the shoulder pain, a lot of times it really just is the scap, or sometimes it's an upper rib, T2 or T3 rib. Sometimes at the same time. So I think over the years, had a lot of AIs, which, again, pretty easy to set. I've even taught people to set it themselves. So, just basically have the hand in, bring the elbow to the center line, and just impulse it up yourself. I just moved my own right there. But I think it's you get used to doing things there. So, but because a lot of times they can't get in all the time for the problem. So I'd either train them to do it or actually have their spouse do it as well.
Okay.
So, it's all about making the patient feel better. Sometimes they can't get to you all the time. So something like that is what I would, help them out with. But again, with the scap though, I think, I can't really give a percentage on it, but a lot of times that scap really, if you can set that properly, it stabilizes the shoulder joint and kind of helps alleviate other problems in the future as long as you can keep that there. So.
Okay. What's your process with adjusting the spine first, obviously?
Oh, absolutely.
And then if they have a shoulder problem and that's not resolving, what's your process look like when you're going to go and start shifting to the extremities?
Well, again, I always clear out the spine first. Dr. Gonstead was always find it, accept it where you find it, fix it, and then leave it alone. That's the key problem. A lot of times people don't know when to leave it alone. We keep trying to do more, but sometimes more isn't better. But more can then take you to the extremities. So when you see that spinal adjustment is only doing so much, then you have to really turn to the extremity and I guess kind of always clear the spine first, but again, start keying on I always go also too, big thing, if we're going stepping back a second here, patient history is key. You need to, know exactly where these problems came from. The history, mechanism of injury. Did they do it playing sports? Did they fall on an outstretched arm? There's a lot of different things. Did they sleep always on that shoulder? These are the questions you have to ask people, because if you talk to people long enough, they will tell you what's wrong and how it happened. But you have to be there to listen. You have to ask the right questions. So again, there's no real time frame. Everybody responds differently. I always tell patients that. They always ask, well, how long is it going to take to make this feel better? And I said, every patient is different. Everybody has different muscle tone. Their activities are different. If you work on an assembly line, you're doing something repetitively all the time, say, for example, with the shoulder. So it's something that you're always putting stress on. So you need to address that accordingly. But as opposed to somebody who just had one specific incident where the shoulder started happening, where it's not something done on a repetitive basis. So I think that's one of the keys there is you have to get the proper patient history, listen to the patient, ask them the right questions. Ask them what makes it better, what makes it worse. Do you remember when this first started? It's all about getting that history, because they will tell you, when it happened. They don't know it, but they eventually, if you talk to them enough about the problem, they'll tell you where it happened, and it'll almost tell you how to fix it, because the mechanism of injury of how it happened will tell you. Because Dr. Gonstead being an engineer before becoming a chiropractor, everything is biomechanically based. So if something moved this way, you move it back that way, and that's how the approach I took to it.
I'm quickly interrupting you to let you know that Electronic Development Labs, or EDL, the developers of the Nervoscope, which every Gonstead doctor uses to look for inflammation and nerve irritation in the spine, is offering my listeners 10% off any Nervoscope purchase on their website. All you have to do is call them and tell them Fano10, or go on their website during your checkout, put in the promo code Fano10, and they will honor 10% off any Nervoscope, including the newest one with the digital readout. Thanks again for listening, and back to our episode. Generally speaking, how much time would you give before you go into the extremity?
Visit-wise, how many times I would adjust the spine before I would go to the shoulder? Well, again, it would go back to mechanism of injury. If I knew that it was specifically happened by, say, throwing a ball, falling on it, I would adjust the spine first, but then that same visit, I'd get right to the shoulder or whatever, knee, whatever it was. Again, it goes back to the patient history and the mechanism of injury, if there was an injury at all or it's something chronic. So, but otherwise, maybe 3-4 visits of adjusting the spine, and then if the shoulder or whatever problem it was, knee, elbow, if it didn't clear out, then I would specifically get right into that after adjusting their spine, of course.
Okay. How about the ribs?
Ribs.
Tell us about the ribs.
Oh, ribs. They're a big problem, because every time you take a deep breath, when you have a rib out, you feel it. And I know I did that once. I was water skiing, and just got done, get back on the boat, and we were going along about 35 miles an hour, and I had a hat on and it flew off, so I just jumped off in it. Well, I torqued out 4 ribs, and boy, every deep breath for about a week, I remembered it. I got them adjusted, but just because of the muscles, at that point, they were just so tight and spasmed, they kept pulling things back out. So ribs, I think a lot of people, I always try to set the vertebra first, but then set the rib after that. There's a lot of times, sometimes vice versa. If it was really symptomatic, I would set the rib first and then recheck them, using static palpation, motion palpation for inflammation there in the area, and then possibly adjust it, then the spine after that. So it depends on how acute it was. So, but
okay. I've seen different sources that talked about different misalignments and different line of drives.
Right.
And I know it can go superior, inferior, but what is it? Are you approximating the rib to the spine?
Yeah, to the transverse process. Correct.
Okay.
Now, I have actually had one. It was actually a guy at Life I played football with actually there. And he actually had a rib anterior. It was actually subluxated off the sternum. And he was in a lot of pain. It was definitely a lot of a deformity there. And I actually set it from behind. I set the vertebra from behind, and it reset the rib. So it becomes, I guess, it's not an instinct, but it's, get a feeling for what the patient needs, and you basically just go with it from there. And every patient's different. There's no cookie cutter that you need to follow. You just got to see what the patient needs, and just you get a feel for what they need, and you do it. So the ribs, again, I'm sure there's a couple different ways to do them. But, the way we, as Gonstead practitioners, basically stand on the opposite side, reach across, lift up that involved side pelvis, and just basically torque it in and give it a little impulse, and usually get a pretty good set on them. A lot of times there's a lot of inflammation and muscle spasm in the area, so you got to fight through that sometime. A lot of times, like at the Gonstead clinic, they'll ice them for a while. I usually give maybe ice for 10 minutes. I'm not big on it, except for afterwards maybe. But with ribs, because there's so much inflammation around the rib head, I would usually sometimes use a little ice on that and then set it, because it helps bring down, because sometimes there's so much fluid in the joint there, it doesn't allow the rib to set properly.
Okay. What's your protocol for x-raying extremities?
It depends on the extremity. I mean, we have protocol for, knees specifically. We definitely have that. I had a patient who was actually, her son wasn't a patient of mine, but she was getting adjusted regularly. He was 8 years old, and they went to an orthopedist because he hurt his wrist. And what did he do? They took a picture of the one wrist. That was the problem. And they showed that the lunate, there was a gap in the wrist there distally. So they were going to go in there and pin it. Well, I told her, before you do that, well, you should be taking a bilateral x-ray. And this is something that you need to do, because you need to compare sides. You don't know what, normal variants are in people. And she brought him in. I took an x-ray of both wrists, and they were exactly the same. So this ortho was going to go in and pin this when it was normal for him. He just hurt his wrist because he fell on an outstretched hand and, had it subluxated. But there was no deformity, and the wrist spacing was normal in both hands. So, I mean, that's kind of things that we need to do. You always need to compare bilaterally, especially because, you're different than I, just the structure of bone, muscle tone. There's a lot of different things that are, normal variables that will look different on an x-ray, yours compared to mine. So that's a reason why you do need to x-ray, and also need to x-ray bilaterally, because you don't know. This poor 8-year-old was going to have something pinned when he didn't need to.
Right. To see is to know.
Yeah, exactly. Exactly. They say a picture's worth 1,000 words.
That's right. So what's Gonstead Extremities to you?
It's been great. It just adds so much to how you can help people. It just opened up a new realm in practice for me, just because it's something you could add to your practice that a lot of people don't do. And it just enabled me to help so many more people who didn't think, you have a patient come in and, they have a problem, say, with a wrist or a TMJ, and you help them. Well, guess what? They have friends that have the same problems. And now they tell them about it, and now they come in. And now you're helping that many more people. So, I mean, just the approach that Dr. Gonstead took, again, being a biomechanical, hands-on type of approach to extremities, it just, made all the difference in the world to me. And that's why it made me want to write the book, just to take it that much further and help other doctors be able to, expand the way they can help other people as well.
Absolutely. That's awesome. It was a huge gift to me. And I know lots of other chiropractors that were out there. Why do you think a lot of chiropractors aren't doing extremities? And if they are, it's kind of like on the fly.
Yeah.
We're not really doing an examination.
Well,
why do you think that is?
Truthfully, I think they're scared. I think they go back to the old medical adage of, do no harm. Well, they're taking it that much farther, and they don't want to go into that because they're afraid maybe they might hurt somebody. But guess what? You might help somebody too. So I think that outweighs the risks of extremity adjusting, because, like I said, it just opens up a whole new world of how you can help people. And you just got to have the nerve and the confidence to study it and apply it in your practice. And that's, it makes so much a difference in people's lives, because they start living with these ailments. They just think, oh, I'm just going to have that shoulder problem. I'm just going to have that click in my jaw. I'm just going to have this wrist pain. You don't have to have it. You just have to have the courage to go out there, study this, apply it to your practice, and get your hands on patients and help them.
What did your training look like when you're in practice?
Well, training wise, again, I went to Mount Horeb many, many times, and just seeing the doctors up there, Dr. Ray Clinton, Dr. Alex, Dr. Doug, Dr. John, Dr. Stoner. I mean, they all gave me something. Every one of them. They just seeing them. I mean, the masters of it who learned under Dr. Gonstead directly just made the difference to me in how I wanted to do things. And then from there, I also went to GMI for 1 or 2 seminars. Dr. Brett Wartenberg also actually worked out there for a little while as well. So he had both sides of it. He got to know the Mount Horeb way and the GMI way, which is a little different, but still had its foundation in Dr. Gonstead's work. So without getting into the politics of it. And we won't go there. But it's just getting all that there. And actually, I took some other outside seminars that gave me a little different look at extremities. But Dr. Gonstead's approach really made the most sense to me just because it was so analytical and biomechanically based. And it's, just learning the how the joints move, what planes they work in, and following that, as opposed to just kind of being abstract about it. There's ways the joints move and the way they don't. So it doesn't make sense to go look at these ways that they don't move if it's not going to help anything. So basically, learn the joints, learn how they move and how they don't move, and just apply it to how you adjust it.
So when we look at the Gonstead chapters, the extremities chapter is so small. Why do you think Dr. Gonstead didn't put a lot of time and effort into expanding that chapter? And what I've heard is Dr. Gonstead didn't even adjust extremities a whole lot. What are your thoughts on that?
Well, I mean, without being in his mind, I can't say that much, but I mean, I guess just again, being an engineer and having a biomechanical base to everything, he did look into everything that he could help people with. That's why he touched on the extremities, but didn't go as in depth. Because again, we have to still believe that everything comes off the spine and everything goes back to the spine. So a lot of times, like I said, if you can clear an atlas, it'll a lot of times clear up a TMJ. So there's a lot of other symptoms. But again, going back to history and mechanism of injury, that helps you key in that it is an extremity problem. But I think also back then when he was practicing, we weren't, mainstream. So what he was doing was, I don't want to say new, but basically it was because he was adjusting different than anybody else did. So I think trying to put that out there was his main focus. So, extremities were definitely something he definitely, gave some insight to, but I think he wanted to key on the spine much because basically everything comes from the spine and out. So, but not that he didn't touch on it because he definitely gave me the foundation for what I did with the book. So I couldn't have done it without him.
Absolutely. Top 2 most difficult extremity cases in your career?
Ooh, let's see. Let me think about that one. One guy I play softball with. He's always injury prone. And he always had a problem with his ankle. He was always rolling it. For whatever reason, somehow or another. Great player. I mean, total stud on the field. But somehow was always hurting himself. And he was always rolling his ankle. And it was something he finally came to me. I kept talking to him about it. I said, if you want to, have it checked out. And it took him about a year to finally get to me. But he did. And, his talus kept sliding out. And basically, I would, set it. And first time, he got up off the table, and he was limping in. And he was like, okay, I feel pretty good. Then he'd go back out in the field and now take time off to rest it. And it became a chronic thing. But after setting it I think it took 5 times and educating on how to kind of footwork properly, like I said, it was difficult first getting him in, but then also getting the set because he had so much inflammation in there, it wouldn't set. I knew what the problem was and I knew I had to fix it. But again, He wasn't the most compliant because he wants to play, which I understood because I was the same way. But again, you got to get in people's heads that you got to help me help you. And if you don't take the time, it's going to keep coming back. So eventually I got him. And I said, it took about 5 times, but I finally got that stabilized. And he finally, continued to play for years and years and, didn't have the problem again. Every once in a while he did. And he would come get it adjusted again. And it was fine. The other one was a TMJ where somebody had some dental work done. And they first of all, I couldn't get them to let me try it because it was just too painful. And I wanted to adjust it so badly, but their internal and external pterygoids were just inflamed and they just didn't want anybody touching it. So had to wait a while, eventually talked them into it. And, finally said it. They didn't like it while I did it, but the next time they came in a couple of days later, they were like, Doc, what you did, I didn't like it, but it helped. And can you do it again? So it's like one of those things where, sometimes the patients are their own worst enemies. They just they want to be helped, but they only want to be helped so far. So, but luckily, we got to it and they didn't have many problems after that. Because usually a TMJ, that's another one. You always have to learn when to leave it alone because it's something we use all the time. And once you set it, it's like the old Ron Popeil. You set it and forget it. So, but again, that's one of the key things that you need to do. Know when to just leave it alone and let it heal. And luckily they let me in there and finally got it set. So
you brought up a really great point. A lot of patients get in their own way.
Exactly.
How did you help your patients get out of their own way? What were like 2 key things?
I think educating them was one of the main things. I think education goes a long way. You can tell them till you're blue in the face, but I think showing them, sometimes bringing in something like this and showing them how things work. Like I say, a picture's worth 1,000 words. And I think if you can educate them enough, but you got to know when to back off as well. Sometimes if you throw too much at them at once, it kind of like hinders their process to allow you to do some things. So like they say, you can't feed somebody a whole elephant at once, but you can feed them pieces of it. And eventually they're going to get that whole elephant. So I think that is one of the key things, educating the patient so they will allow you to help them. So
how did you educate your patients? Did you have a process?
Process-wise, I would kind of first, depending on what the joint was, I would educate them about the joint, show them pictures. If I had, a actual model of it, I would show them how things work and how their injury happened. Put their hands on, here, hold this. Because sometimes when people have it in their hands, they actually kind of grasp it a little bit better mentally, and they can understand what happened to them and what's going on with their body. After that, I would, again, give them a little bit and then back away from it. Let them process it. I wouldn't try to force it all in one visit because, like I said, sometimes it's too much and they can't grasp it. They know the pain they're in. They don't want to be in the pain they're in, but they're afraid of more pain. So if you can just give them a little bit at a time, I think it helps build a foundation of the trust between the patient and the doctor, and it allows you to do more things, especially like with extremities, because again, extremities are, something that sometimes people are a little bit more apprehensive. Laying down on the table and getting adjusted, they're good with it. But sometimes, messing with their jaw, messing with an elbow or a knee that they've had chronic problem with, they just, they know the pain they have, and sometimes they can accept it. Whereas if you can give them this little foundation of, basically the anatomy of it, the mechanism of how they hurt it, what is wrong, and they just back away. The next visit, you come in and say, hey, how's that knee today? Would you like me to try to see what we can do for that? But again, don't force it on them. Sometimes you do that, they're going to push back. So just like when you put your hand on someone, you push them, well, they're going to lean into you and push back. Whereas if you can just a little bit and back away, I think they'll be more apt to allow you to do things with their extremities.
So what I'm hearing you say is little nuggets.
Exactly. Exactly. Piece by piece, give it to them. Don't throw it all at them at once. So,
You mentioned TMJ was your favorite to adjust.
it really was. After I had that first patient, it wasn't even mine in clinic. It just kind of like, I was like, wow, can how to make an impact in one extremity adjustment right there like that. This poor girl hadn't opened her mouth in more than an inch in 11 years. And for just to set it one time, and it had me there, you had me hello.
Would you say it's the most emotionally impactful correction?
Yeah,
Like, what would you say?
absolutely.
Okay.
Without a doubt. It really just, and I was just, happy that the other clinician who was my classmate allowed me to come in and help her. So, because a lot of times, we have a little bit of ego and think we can do everything. And you can't be afraid to ask for help. There's plenty of other doctors out there who've seen things that we haven't yet. And if, just reach out. There's plenty of us out here who are willing to help and have seen things that you haven't yet. And we'll be more than willing to help guide you through, helping these patients.
Awesome. Thank you. What is the most difficult extremity for you to learn? What's a difficult joint, I would say?
Let's see. I would probably say knees, because it's tough to get a really good set on them just from the anatomy of it. I had a friend of mine, well, actually it's a nephew of mine, who had a problem with somebody's knee, and he called me up, and it's like, they really won't let me do much to it. This is the pattern of the pain. He sent me a picture of the x-ray, and I, drew my lines up on it and everything. And he was doing the opposite of what needed to be done. Like his exam and everything led him to a certain diagnosis of what it was. But again, listening to the patient, after I asked him specific questions about what was the pattern of the pain, what brought it on, what helped alleviate it. And I think because it's just a large structure that, you have so many different ligaments there holding things in different directions there between the collateral ligaments, the anterior and posterior cruciate, the meniscus. A lot of times you can have a small meniscal tear and it's not allowing you to set the joint properly. So you have to kind of, as we know, flex the joint a certain way and get that piece to sit flat, and then you can adjust it properly. But I think the knee really was one of the ones that, again, because people don't really let you take it into full extension when you want to try to set it. So I think that was one of the more difficult ones to really grasp and help people with, just because they don't want to let it go. So they just, they fight you on it.
In your book, you talk about flexing or extending to that certain position.
Right.
Can you expand on that?
Every joint has a certain amount of flex to it, and it's like, I guess, what's the word I'm looking for here? It's just like when you're adjusting, say, in cervical chair, you have that point where you get the point of tension, and same thing like with the knee there. You have to get it to that point of tension where you can feel the impulse. There isn't any more slack to the joint, because you don't want to go through that slack too much, because then you can over hyperextend it or, cause more harm than you're doing good. So you have to get to that point, just like, any adjustment, where you follow it in, and then you take the slack out and then set the joint. So I think that's something that really need to really practice a lot. And again, you don't get too many hands on as many knees as you could and should. So it's just basically getting, I don't want to say soft hands, but it's something that could touch that you get. Like a lot of athletes have it. If you have that hand-eye coordination, you get that feel for the joints, and you can feel where that slack is coming out, and you know when to impulse. So I think that's one of the main things, just being able to feel that there's no more slack to the joint, and then that's where you have to set it. So.
Awesome. Go back to yourself many years ago, writing that extremity book.
Oh, yeah.
What advice would you give yourself?
Oh, I would probably tell myself to maybe look into other methods as well, and try to add it to what we had from the chapters. Again, like you said, Dr. Gonstead, put down just enough to get us, eager for extremity adjusting, but didn't really expand on it. He kind of teased us a little. He said, all these different, the different joints. He gave a nice analysis of things, but again, it was just a little tease. So I think that helped. But I think if I could do it again, I would probably look into other ways, because I've been adjusted different ways, extremity wise, and some work just as well or even better than what we have with the Gonstead work. But again, it also gives us alternatives too. If I could, get into other ways. So I know Dr. Working had a couple of different ways of doing different joints, and I thought some of them were very good. And I think it expands on it, because sometimes we can't get things to move properly, using the one method. So if we could expand it, and if I could have a little bit more versed, again, because I was right fresh out of school when I wrote it, and I was still wet behind the ears, didn't have all the experience, so I think if I could have done that and got out a little more and expanded my horizons and some other techniques that maybe have a little more extremities, different ways to do it. I mean, I wouldn't abandon it. I always try the Gonstead first, but if any other way, if it doesn't work this way, okay, let's try this instead. So at least it would expand my way to be able to help people that much more.
Very cool. Well, where can the audience find you, especially if they're a Gonstead student or a Gonstead chiropractor that want to learn more about extremities?
Well, truthfully, they can catch me through you.
Perfect.
If there's another way, I'd be more than happy to help out. And if you have other podcasts that you'd like me to be in on, I'd be more than happy to share whatever I've picked up over 33 years of practicing, and see if we can get the next generation, involved in extremities that much more, that would help them help their patients.
Awesome. Dr. David Sheekey, really appreciate your time and your wisdom and your heart, helping us to become better.
It's my pleasure. I really appreciate this chance to just put it out there and possibly help some future doctors out there get their hands on some extremities and help more people.